We are live now, doctor.
Yeah, just a minute, my screen. A very good evening, everybody. I thank all of you to join here today on this webinar with YOSI Career Portal and Team YOSI. So YOSI is an society that serves the Young Ophthalmology Society of India. So this was started in year 2014 by Dr. Harun Arora and Dr. Vijay Sharma, and it is now around 5,000 members strong. So we have different presidential working groups in this, which were earlier designed by Dr. Sonal Kalia. And YOSI Career Portal is one of them. So these are our current office bearers, Dr. Devakant Mishra as a president, Dr. Sonal Kalia as a past president, Dr. Karan Bhatia as the vice president, Dr. Nilesh as a secretary, Dr. Aditya Sethi as a treasurer, and Dr. Prasanna V. Ramesh as a joint secretary. And this is our executive committee members who are 20 in numbers and they lead all the different PWG groups. So in the year 2025 March, we started this YOSI Career Portal with the launch of our app, which was designed by Dr. Nilesh and his friend Mr. Amit. So what they did was they tried to put they tried to develop the app in such a way so that it was free to use and it was easy to use for both the employers and employees both. Then we had our series of webinars with the AI's governing bodies. Then we had some very good webinars with our esteemed panelists from different big institutes of India. Then we had a webinar on successful running of a clinic, the same on finance and private clinics also. And this was our last webinar on the financial confusion. So then in the year 2025, again, we held a YOSI Job and Fellowship Carnival in the YOSICon, which is the annual conference of YOSI Society, where we had this Job and Fellowship Carnival where we had a lot of institute who participated with us, and we had so many activities where people got employed for their jobs, and we had fellowship interviews on the spots also. So this was one of the highlights of YOSICon. And today we welcome you for this webinar of ours, which is Beyond Clinics Transforming Eye Care Outreach. So this is partnered by Remedio. So I welcome our chairperson, Dr. Arvind Kumar Maurya, sir, and Dr. Meena Kumari, ma'am. And with us, we have our panelists, Dr. Samita Milani, ma'am, Dr. Isha Agarwal, Dr. Avnish Upadhyay, sir, and I'm the moderator for this session. With me, I have my co-moderator, Dr. Gunjan Buddhiraja, and we have our two talks by our young dynamic bios. One is by Dr. Prasanna V. Ramesh, who is going to speak on transforming eye care outreach using comprehensive eye care solutions with offline AI technology for early screening in remote areas. And we have another talk by Dr. Sumit Grover, who is going to talk about taking eye care beyond four walls, ophthalmology outreach principles. So over to you, Dr. Gunjan, for the introduction to our chairpersons and panelists.
Thank you. So I welcome all of you to this webinar. And as Dr. Sunandini already mentioned, that we have high dignitary people here today, and now we'll be getting all the experiences from them. So I'd like to invite Professor Dr. Arvind Maurya, sir, and I don't think he needs some introduction, but still I'll introduce him. So he's the first Indian to win Ophthalmic Star Award at Amsterdam ESCRS 2021, and he has 50 AIOS, 21 DOS, 19 Ecoin, and international, national, and state level awards, including first to receive the AIOS Senior Academic Achiever Award in 2021. And he's been heading many projects which are based on artificial intelligence on diabetic retinopathy, glaucoma, and myopia, has multiple 750 international and national presentations. He's a section editor, and he has performed a lot of 35 around live surgeries, and he's a program director at AIOS Disc OS certification course. So I welcome you, sir, tonight.
Thank you. Thank you, Dr. Gunjan, for the nice introduction. Thank you so very much.
Can you move next slide, Dr. Sunandini? I welcome Dr. Meena Kumari Ramesh, ma'am. She's a cataract surgeon and medical director at Mahatma Eye Hospital, Tiruchirappalli, Tamil Nadu. And she's a senior ophthalmologist with over 25 years of clinical and surgical experience. And she's renowned for high volume cataract surgery and advanced phacoemulsification. and she's a medical director managing 50-bedded NABH accredited eye hospital, and she has a lot of expertise, and her credentials are marvelous. So she has a very extensive experience in community outreach and blindness prevention programs, and she'll be sharing her experience tonight with all of us. Next slide, please. So I welcome Dr. Prasanna as our speaker. Again, Dr. Prasanna also doesn't need any introduction. He's the research director and glaucoma head, sorry, at Mahatma Eye Hospital, Trichy, India. And he's editorial board member also at IGO. And currently he's a joint secretary at YOSI. So welcome, Dr. Prasanna.
Thank you, Dr. Gunjan.
Next slide. I welcome Dr. Sumit Grover, sir. He's an assistant professor of ophthalmology at AIMS, New Delhi, and he's an experienced ophthalmologist with strong foundation in clinical ophthalmology, public health, and community eye care. And he's serving at the National Cancer Institute at AIMS, and also previously worked as a research officer in community ophthalmology at RPC, India, New Delhi, and he has contributed to several national level health initiatives, including the National Trachomatis Trichosis Survey, PMJ Ayushman Bharat Package Revision, and WHO's Rabi Field Protocols for calculating ERC and ESCS. I welcome you, Dr. Sumit, and will be privileged to have your thoughts tonight as
Thank you.
as a speaker. Thank you. I welcome panelists as Dr. Samita. She is a consulting ophthalmologist and partner at Mulani's Eye Care Center in Pune. And she has done her long term fellowship in cornea and anterior segment and multiple trainings at different high premier volume eye centers in India. And she's holding eye screening programs for schools and rural areas to diagnose and treat preventable blindness, and she's a visiting consultant also at Guru Nanak Foundation Hospital, and she's also involved in Orbis camps and also screening programs. I welcome you, Dr. Samita, tonight.
Thank you, ma'am. Thank you.
I welcome Dr. Isha. She's a consultant ophthalmologist and oculoplastic surgeon in Dibrugarh, Agartala, and Dehradun, India. And she has done multiple courses and also fellowship advanced training in oculoplastic and reconstructive surgery, and also has been an international observer at UCLA for 3 months and Singapore National Eye Center. She has trained more than 40 young ophthalmologists in SICS and phacoemulsification, and she has won many awards. And she's also got a bursary grant and Hinman Prize at ASCRS. I welcome you, Dr. Isha.
Thank you, Dr. Gunjan, for the warm welcome.
Now I like to introduce Dr. Avnish. He's a senior VR consultant at IQI Hospitals. He's also been a former consultant at Shankara Deva Netralaya Guwahati, and also former treasurer of YOSI. And he's done more than 4,000 VR surgeries, and his special interests include macular surgeries. I welcome you, Dr. Avnish, tonight.
Thank you, Dr. Kunchan and Dr. Sunandini, for having me here. Thank you so much.
Thank you, sir. So I welcome Dr. Sunandini. She's the HOT Department of Ophthalmology in Bhagat Eye Hospitals, and she's currently an executive member at YOSI. And including me, I'm also a executive member of YOSI and core team of YOSI Career Portal. So now our we can start the first speaker, Dr. Sunandini.
I think we should just take some simple
Yeah, yes.
comments from our chairpersons first.
Yeah, sir. Dr. Arvind, sir, can you unmute yourself?
Yes, so very good evening to all of you, and it's such a nice platform, and it's an honor to be here. And this artificial intelligence here, as well as the teleophthalmology, it's going to stay there and will play an important part in our life. So we need to get adapt to it, and all the very best.
Thank you so much, sir. Dr. Meena ma'am.
Yeah, it's very exciting to be with all of you. And you have very carefully chosen senior citizens as your chairperson. But Dr. Arvind seems to be younger than me. But it's very exciting and to see YOSI so vibrant and with the clarity and full of activities. I've been watching that through Dr. Prasanna. I'm very happy to be among you all, and I'd like to share my experience too. But now we'll start with the speaker.
Thank you so much, ma'am. Dr. Gunjan, over to you.
So I would like to invite Dr. Sumit Grover sir for giving his talk for the topic tonight. Thank you, sir. Can you start your slideshare?
Yeah, thank you, Gunjan. I'll just share the screen. And please tell me, give me the prompts that yes, my screen is visible and I'm audible. So, can you see the screen, everyone?
Yes, sir.
Yes.
You can.
And am I audible?
Yes, you are very well.
Yeah.
Okay. So, thank you, Yosi. Thank you, Sunandini, Gunjan. And nice to see our boss here, Dr. Arvind, Dr. Meenakshi ma'am, all the senior panelists, and my June-born buddy, Prasanna here. So I'll be talking about something about the community eye care services. And through discussion, I aim to cover the following: explore the role of community eye care services in providing accessible eye care and some of its principles, highlight how newer portable equipment can complement the traditional in person comprehensive primary eye care services, and moreover, explore the emerging trends in data management and advancement in remote audits and monitoring of the primary eye care services. So, Gunjan, because I'm seeing only my slides, if if I'm not able or like if I'm not audible or if my slides stops, so please give me a prompt to me, right?
Sure, sure. We can see it
Yeah.
very well. Please.
Yeah. So, primary eye care, what is that? It is the provision of appropriate, accessible, and affordable care in a comprehensive and competent manner, and it's the first contact for eye care services as well as the lifetime of continuing care. It is also integrated and coordinated with general health services and based on the principles of integrated people-centered eye care, like from birth of the child, from ROP screening to the ARMD. It covers all the continuum of life, and it should be given to the people by the competent and expert management and decision making. These are very critical in promoting quality and efficiency of a primary eye care services. Now, many of us usually confuse community ophthalmology with the community eye care services, and I often hear these things that community eye ophthalmology we cannot do, we are not trained in community ophthalmology, you are being trained, and things like that. So I want to clear that community eye ophthalmology is a very broad umbrella term, and it encompasses the community eye care services which are promotive, preventive, curative, and also has the referral and rehabilitation part. Thus, community ophthalmology encompasses national eye care services, surveys, policy and planning, things like that, biostatistics, epidemiology. But community eye care services consist of eye camp, school screening, and that can be done by any young ophthalmologist, any private practitioner, any corporate practitioner, or any group practice. So we are talking about the community eye care services here. Also, we can also judge we can also assess the behavioral and social impacts on eye health by our community eye care services, like factor influencing the decision to seek eye care, quality of life after treatment, individual behavior through treatment adherence, urban rural disparity, cataract surgical coverage. So if we are just working in our four-walled eye care setup in a tertiary level, we will not be able to assess these things. But if we move out of the four walls, then we can assess all these things as well. The eye economics is also very important. We also learn that what are the allocative efficiency. That's because we have very limited resources, where to allocate, what resources to allocate for each activity, what is cost benefit analysis, and also the technical efficiency, that daycare cataract surgery versus inpatient stay, mobile versus fixed vision centers. So these can be addressed by cost effective analysis and only be assessed when you move out of the four walls. Also, the community eye care or eye care. This balance is very important, especially for all our private practitioners. So we have to, balance our altruistic goals and self-serving goals, contributing to the society, community involvement, etc. And self-serving means sustainability, ensuring the sustainability. If you're too altruistic, then it will pose challenge to your sustainability. But if you're too much self-serving in your community outreach or community eye care services, then eventually you tend to lose the trust of the society or the community. So you have to maintain a very fine balance between these two things. I quote a very famous quote by Helen Keller: the only thing worse than being blind is having sight but no vision. But also, the other worst thing is having a good number of tertiary centers in the country but no vision centers. And the slide is very, I always present this slide, very, very sad slide, that according to Vision 2020, Right to Sight India, this should be, the right one should be our eye healthcare pyramid with maximum number of vision centers. But according to the latest data, it is not a good things to see. We all have many things, but vision centers are currently lacking. Excuse me, the Delhi pollution has taken over me, so please excuse me for this frequent coughing. Now, what are vision centers and how we can, what is the principle behind that? So vision centers, there are various models. These are fixed centers which can be integrated with other general healthcare services, like you can integrate them with other multi-speciality or general health services like dispensaries, government dispensaries, private dispensaries, multi-speciality hospitals, or they can be your stand-alone primary eye care services like your vision center only for eye care services, and they can be mobile units as well through the mobile vans or the teleophthalmology. And this slide shows the hub and spoke model, where the hub will be your full-fledged tertiary eye care center. For us, it is RP Center. For Prasanna, it will be Mahatma Eye Hospital. For Sunandini, it will be the Bhagat Eye Hospital, and the vision centers are the spokes. So that is how you can envision the vision center by hub and spoke model. And we need human resources and infrastructure. Human resource, what we need are the expert optometrist, the data entry operator, which is optional, or some health assistant or multi-purpose health worker. Just two people are enough for setting up a vision center. And equipments, the essential are the near distant vision chart, trial set, trial frame, vision testing drum, retinoscope, streak retinoscope, magnifying loupe, epilation forceps, and desirable are slit lamp, ophthalmoscope, lensometer, and autorefractometer. And these portable devices by many companies like Remedio have revolutionized this. Previously, we used to have this kind of slit lamp. Now we have this tech savvy, mobile based slit lamp. Then fundus autorefractometer by various companies, like this is one model, this is another model. Then portable NCT, portable visual field analyzer is there, portable fundus camera is there. And now the Remedio has come up with this beautiful kit where you carry your equipments, you carry your vision center along with you, whether in the mobile van, whether in a fixed facility center. And for this, my June born buddy Prasanna will take this forward and will discuss these things in detail. So this is the Vision Delhi, a community eye care initiative by RP Center. And here the hub is our Department of Community Ophthalmology at Dr. RP Center AIMS, and the spokes are our 17 vision centers. And all the 17 vision centers are very smart vision centers, which includes all these portable devices, and we are using them very happily. Now, the more important part of my discussion today, it is the data management, which is use of open source technology for monitoring and audits in eye care program. Many of us face a challenge that we tend to avoid community eye care services because we think that data management is very cumbersome. How can we maintain so many registers? How can we maintain the monitoring audits? How can we compile publication? The things will be very cumbersome. But I'll introduce you to this ODK platform, which is open source initiative. And what we are using at RPC are these many, registers. We have primary eye care register, health education register, voluntary training register, then referred patient register, cataract surgical record, DR report, and school vision screening and low vision register. I hope Gunjan, uh, I'm with all of you
Yeah, sir.
just to test in between.
Mm.
Then, what is this open source? It is a software which is free to use, redistribute or modify, and adaptable into derived works for everyone and anyone without discrimination, whether you are a private practitioner, government employee, or group practice, corporate practice, or an NGO. So it's an open data kit ODK platform, and you can use it online or offline. What you need is a server for database. Either you can pay them for the ODK cloud, or if you have your own server, like at our end, we have our own server at Community Ophthalmology, and AIMS has its own server. So if you have your own server, then you can create a virtual machine, install a docker, and these things can be done by a very much computer, any computer program, and this is all free of cost. And then you can install this ODK collect, uh, this app on your mobile, Android or iOS. Then on the ODK Central server, you will see this kind of a platform, and you can start your new project. Like for example, you can start your PEC database, Vision Center database, or DR survey or corneal opacity survey like this. This was my console when I took the screenshot. Then after creating the database, this is only one time. You can start with the Excel format. You can design a form, the type of data, the name you give, the label it. You can design it whether it is required or not, filter, etc. So you can design. It is also a one-time procedure, and after that, this you can design these many kind of list of forms, and then you can make a admin to one of the person and give rights to many users for data upload like this. And for to your optometrist or the person you send to your mobile vision, this thing mobile van or vision center, you can give them just this mobile or their smartphone, and they can put this app into install this app. So in their app they will see a form like this. Like this is page wise form. I took a screenshot, and it is very much self explaining. Then that they have to select the vision center, that what vision center, the patient OPD register, name, etc., vision, then diagnosis, OPD, then what was the advice by the optometrist, things like that. And then this is the summary which you can see at the time of the when the optometrist or the person will submit this form. And this is how the data will be uploaded. In the good thing about the app is that you can upload it whenever you find the internet. Otherwise the data will be stored offline. You don't need internet in the remote areas while putting up the data into the app. Each patient has the unique PEC number. You can design it, and then it will be used to link the patient data across various forms, and which will be used by the Strata software. And forms are very much editable in the server even after they are uploaded. And ODK Central maintains a full audit trails of the edit. And for forms can include the images, the GPS. This thing coordinates the signature and many other things, the QR code, photos, etc., where anything in that app apart from the data. So we have the data now. What we can do, we can link this data with the reported patients to our who have reported for cataract surgery, then link this to the cataract surgical data and the follow-up data, and we can analyze the data by using Strata software, and monthly report can be prepared and the reviewed. This is the example of a monthly report, that how many gender disaggregated, how many males were there, females were there, screened, refraction conducted, spectacle prescribed, spectacle book, referred to your center, then referred for cataract, reported for cataract, operated for cataract, what were the follow up, refraction conducted or not after 4 weeks, what were the status. Also give us this kind of picture, that how many patients were having the diagnosis-wise data separation, disaggregated data. Then DR screening, how many males were there, females were there, and according to this Scottish classification, uh, what were their grade of DR. Then health education events, how many were done in the various centers, number of health education events, number of participants, things like that. Also, we can also include the disability score by the WGSS score we have installed in the PEC register, so that we can generate the inclusive disaggregated disability disaggregated data as well. So the cost of setting this system, server provided by AIMS. So we have virtual, this is free of cost. Time to set up server 2 days. Time to develop XLS form 2 to 3 days. Person to manage the system can also do the data analysis. And same person who were handling Excel data earlier now handle OTK. And also, if anybody is interested, we have all the forms already made, so you don't have to develop these XLS forms. You can just take us from us. And this is also a daily report PC which I get on my mobile. This is the old OPD, new OPD of a particular day, that how many persons came, what were their diagnoses, and what were the list of referred patients. Then DR clinic details, that how many patients came, how many were female, males. It's a like daily data which I get. Health education, and then reach in program, cataract operated, number of patient reported, and their summary statistics. Even it shows that reason for not admitting for cataract surgery, and then cataract surgical outcome, number of patient operated, type of surgery, cataract surgical outcomes. These can also be very much easily can be uh, submitted in the data very much easily, and also the follow-up of the cataract patients. So conclude, technologies are freely available that can be utilized in eye care programs for data management. It helps monitor inclusion, whether it is gender disaggregated data, disability disaggregated data, or the urban rural disparity. You can check. Then very reliable thus far for us, and data is kept secured with full audit trail. And it also has eliminated registers in our PEC clinics, reducing the carbon footprints. So I think it's a paucity of time. I'll skip this vision center DR screening model at RP center. I just wanted to show this slide. This is very important, that how a simple Innova high cross car was changed into this mobile this thing. The back seat was removed, and also the back boot space was beautifully utilized to make things for indirect ophthalmos direct ophthalmoscope, vision chart, and many other things. It's a very compact thing, and if anyone wants that design, that how to make a mobile van out of it's like do it yourself DIY thing, so you can contact us. Also, for any IEC material which you want to install in your vision centers to raise the awareness, as Dr. Minakshi was mentioning initially, so you can also contact Dr. RP Center AIMS Community Ophthalmology. And yeah, and if I had this something about the community ophthalmology, its prospect, significant relevance in this DGO. These are some further reads, and how NGO can, the experience of effective community eye care services by NGO. We have written this article by me and Dr. Harsha Bhattacharya and Dr. Nilut Panna. These are something which can be of help to anyone, or even the glaucoma, and how to set up a glaucoma screening services or glaucoma case detection services in your outreach programs, can see this thing. So I'll just skip, and thank you. I thank you, audience. Thank you, Yosi, and I would like to thank my chief, Professor Radhika Tandon, my mentor, Professor Vashish, Dr. Vivek Gupta, who has really he's a stalwart in setting up this ODK platform for us, and whole team of Dr. RP Center of Ophthalmic Sciences, AIMS, New Delhi. Thank you so much.
Thank you so much, Dr. Suman. I think that was very enlightening talk by you, where we are actually learning that even a portable device can be used for doing eye care camps. I think I'll ask my first question to Arvind Maurya, sir. Sir, how feasible do you think it is now in today's time that we do all these outreach camps in government medical colleges? Because most of the time in like Delhi being a place where we have a lot of villages which are in the peripheries of Delhi or bigger cities, how feasible do you think it is with the government medical colleges in small areas to do eye care outreach camps?
Yes, in my experience, right from my PG days and then the super specialty and even the JJ hospital is a very big center, tertiary, more than I think that is a Apex ophthalmic eye care center in Mumbai for the Maharashtra. So they also did a lot of these camps in the most peripheral and the tribal areas of the Maharashtra, as well as the border area of the Gujarat. So yes, it is feasible because the thing is, we being a part of the institute, we are more well versed with the problems because we are getting the referred cases. So we know what exactly is wrong with the psyche of the people, the patients. They are highly ignorant. Most of the time they are turning up when the cataract is highly mature and there is journal dialysis or there is extensive this glucomatous optic atrophy. So by going there, so along with the kits, specific kits in the camps, educational means the kits which are very helpful, like the audio as well as the video, the pamphlet form. So yes, of course, and it will be relevant in the longer run to come.
Longer too.
Yeah.
Thank you so much, sir. My next question would be to Meena ma'am. Ma'am, being from a semi-charitable or charitable eye center, like how do you start with this eye care outreach programs in these areas? And the same question to Dr. Avnish sir also, because I think you are both from institutes. You can tell us how the institutes actually work on this programs, how they start and what they do to bring the patient down to the his tertiary hospital or the secondary centers. Ma'am, you're not audible, ma'am. You're on mute.
Dr. Sunindra, you mean by using tele-ophthalmology or
Both,
practice?
ma'am. Both, ma'am. Matlab bringing the patient to the Hayes hospital as well as the teleconsultations too, ma'am, from the vision centers.
So, our experience recently is with Rotarians. They call it Project Orange, and the centers are called the hybrid eye vision centers. We find it very encouraging. And for example, there is a center in Mayavaram. That's a place not very big, not very small. There, within this 1.5 years, we have identified nearly 800 and odd glaucoma patients, undiagnosed, undetected, all this while. And teleconsultation is done immediately with the base hospital. It's extremely useful, and we have train frequencies, and the patients whoever need further investigations or who need surgical treatments, they are transported by train. It's just 2 hours journey. They come here and they get operated depending on their socio-economic status, either free of cost or in a very, very concessional rate of just 5,000 rupees for a cataract. We can afford that among the good practice. This is not going to pinch in your budget. And conducting school screening program, we transform the volunteers as vision screeners. We give them training for 3 or 4 days, and then 2 senior sisters assist them, and we go to schools and screen the children. And they are brought to the hybrid vision centers for cycloplegic refraction, and it's very much appreciated. They are consulted from teleophthalmology from here, and now with the Remedio, we have started practicing even in our outreach programs like District Blindness Control Society, all our camps headed by senior technician, and the Remedio suitcase with all the portable equipments, and teleophthalmology from base hospital. Recently, we brought just last week 24 cataract patients for surgery. So the efficiency is very good. And Remedy has got artificial intelligence, so glaucoma, ARMD, diabetic retinopathy, somewhat like you are not much apprehensive. Is anyone going to miss that? If we send an optometrist, he may not read a DR and all that. So this artificial intelligence, what they've incorporated, is quite supportive, Dr. Sunandini. It's
Thank you so much, ma'am. I think that is how from the institute where I have also passed, they also do that. They have a lot of vision eye centers from where they get these patients. They actually train the optometrists like that so that they can go and screen the cataract, and they take the help of these the surpanch of the village head, so that the village head can communicate with the villages, and then they can get those people on the buses, and we do the surgery, and then they send back. Dr. Abdish, your call on this question, that how we do them in the institutes.
Yeah, thank you, Dr. Sunandini. I think, first of all, I think Dr. Sumit had a very good presentation where he did speak about something called as hub and spoke model, which works in our setup where we have multiple chains of hospitals which is linked to a base hospital. So we have a cluster of hospitals in one set of area, and we have a hub center, and then we have multiple, I won't say a center, but we do have hospitals in those areas. So I'll just talk in respect to retina, because a retina-based screening is what we tend to do at times. And for most of our patients who also come for cataracts, we do try to do a retina screening as well as we do CTs. So one thing which we tend to do is, as far as training is concerned, we train all our optometrists, as well as if we have something called as personal relation officers, which we have in our setups. So we do tell them to, at least learn the OCTs, or at least you can use the non-metric camera as well. So first thing which is very important is actually teaching these people and to have a protocol as to what needs to be picked up and what are the red flags, or maybe what are the pointers which these patients needs to be referred. So that is one. Second thing which actually happens is when you have these if the patient has some disease, these patients do need to be, what do you call, on-site explanation of these patients is very much important, because even if you screen these patients, if you don't explain them what the problem is, they may not come for the treatment. They are a bit apprehensive. So second thing which matters is on-site explanation of what the problem is, and that needs to be nicely discussed. So that can actually happen by telecommunication, or the patient can be brought up to the center and can be explained. So in cases where and that is where, having fundus cameras or maybe having a smartphone based images kind of works for everyone. We do have WhatsApp based imaging system as well, where somebody is doing an OCT, that is referred to the retina specialist. And if required, we do the teleconsultation for that patient in that 1-2 hours, if the patient is going to stay back, or else if the patient is explained by the local doctor, and so that actually helps in what do you call, increasing the screening as well as treating those patients. So this is what I can talk about. Yeah.
Thank you so much, sir, for your insights. And my next question will be to the private practitioners who are running their clinics, as well as they do so much of charitable work also. Dr. Samita ma'am, how do you combine the private practice with the charitable cases, and you ensure that these patients comes to you? And the same questions to Dr. Isha also. Dr. Samita ma'am, are you there?
Yes, thank you. So compared to everybody here doing a very large scale operation, I am running this since the past 10 years, but in a bigger way after COVID. So it is tough. I have trained a few of my optometrists and some staff to go out into we in being in Pune, I'm mostly in urban slums, and of course patients have a lot of questions because we are not a big board hospital. But basically, the aim initially in any area is to get one or two patients in. Once they have a good kind of feedback, and you give them a good service and you give them good outcomes, they'll always go back and send more. So I think that nothing in this kind of bracket of patients is better than a good chit or a clean chit or a good report back. So one is that, and of course you do have to train and your staff to be very empathetic. So a lot of times in community outreach, the our the least so-called surgical person like the social worker, if they're not empathetic, if they're not caring towards the patients, then your reputation starts getting ruined from there. So empathy is super important, bringing those patients in. It's very difficult to separate my premium paid practice from my charitable outreach practice. That's a big challenge for most private practitioners, because how do I justify charging almost nothing to a charitable case versus premium rates to a high end case. So it is important to create some kind of differentiation, which we are working on. And many of the sessions that people talk about, creating different entry points, different OPDs, it's tough. But I just feel that being someone in ophthalmology, if it's my kind of responsibility to the community to do as much as I can. And looking at the rates of blindness and childhood blindness especially, now I've moved track, as I was telling Meena ma'am, from cataract, which honestly everyone is doing, to pediatric glaucoma, which not a lot of people are doing. So hopefully the next few years will be more learning for me. But you just do it because you feel it's extremely
Empathetic.
gratifying. It's extremely
True.
gratifying, and yeah, that's, you find a way in your own system.
Thank you so much, ma'am. Dr. Isha, your comments. Dr. Isha, are you there?
Yes, I'm here. So I would completely agree to what Samita ma'am has just said, and also Dr. Meena ma'am and Arvind sir. So at our setup, what we do is we have at both our setups, we have our tertiary eye care centers, and around that tertiary eye care centers, we have our vision centers. So vision center is basically a fixed location, yes, and we also have a fully functional mobile eye clinic that kind of goes through different districts and also places. So how do we select these places? These are generally mapped out in the course of the month, like where would they screen those patients, where wherever the need is there, they would kind of send the mobile eye screening vans there, and they would screen the patients. So our technicians and optometrists, they are trained to screen cataracts, glaucoma, with of course the remedio set, any retina conditions, because uh, they can kind of, which is a normal connect to a doctor through teleophthalmology, and some needs like urgent referral and some can delay the referral. So say in a camp we had an OPD of 100 patients and 30 referrals. So to make sure those patients turn up to the tertiary eye care center, as in the base hospital, uh, we kind of ensure that the team leader, the camp leader, has a word with the ASHA worker or the village head that, sir, we screen so and so patients and we have referred these many patients, and this is how critical the situation is, and you should kind of refer them to the tertiary hospital as soon as possible. And also our car would be there to pick up the patients and drop them back. So that's how the efficiency and turn up of the patients increases a little more. And that's how we do on a regular basis, on a daily basis.
Thank you so much, Dr. Isha, for your insights. And with this, I would like to ask our second speaker, Dr. Prasanna, to give his presentation. Now that we are all done with
Am I
this, that
audible?
how to bring the patients. Yeah, you're audible. Yeah.
Yeah.
Dr. Prasanna, are you ready with your presentation?
Yes, Sunandini. Yeah,
Thank
hope
you.
my screen is visible.
Yes, it is visible.
Trying to go to the full screen mode, and hope I am audible and visible as well. Thank you. Yeah, perfect. So thank you, Sunandini, the YOSI Carrier Portal webinar team, Gunjan. So transforming eye care outreach using comprehensive eye care solutions with offline technology, as Dr. Sumit, I call him my favorite June born buddies. We almost share similar birth dates, who covered almost everything on early screening in remote areas. And Though I would say I don't have any financial disclosures, but some of my videos are mostly customized on our center's catering its synopsis with Remedio. And thank you for the opportunity and to all the esteemed panelists here. And this is the only picture I have with Dr. Sumit, one of my favorites at YOSICon when I was playing the Joker role with my June born buddy again. So he covered almost everything that the principals would demand. And I'm just going to just shift a bit more to the practical aspects, what our center has done for the last few years or so. And most of it is again the brainchild of Dr. Meena ma'am, which I'm just trying to express in this webinar. So the clinical challenges which we faced was the limited time and of course COVID, comprehensive eye care, which we wanted to do in a very non-portable, a portable manner. So that's when what we realized was globally there is approximately one ophthalmologist for every 1 lakh people. Again, that's a major challenge because the unreaching part, again, Arvind Ponti came with a paper called Uberization of eye care. So what can we do to, reach out to people with the retinal diseases, refractive errors, cataract? As you can see, the numbers are quite alarming with 3.3 million, 88 million and 94 million respectively in the global platform. So the need of the hour was always portability, affordability, ease of use, clinical validated, because with AI, we need a validated software, right? And scalability. So we implemented the portable eye care kit even in our routine OPD. These were times when, either if it's a high volume or even during COVID part, where we brought in LASR, VR perimetry, again, a non-portable, no financial disclosure, a very portable instrument, where we can complete the evaluation within 10 minutes is what our center aimed at. And this bag that the Remedio Insta Eye Clinic gives us, it's around 6 kgs. These things make a difference. Working offline, as Dr. Sumit beautifully covered, requiring minimal training for our paramedical staff. So this is the portable bag which has all these instruments, tonometry, fundus photograph, slit lamp, and an auto refractometer, whatnot. Because these are the 5 common scenarios that I always feel in India in our setup: cataract, infections, diabetic retinopathy, glaucoma, and uncorrected refractive error. If you are able to crack these, I think we are through. And the AI technology that the Remedio has actually given us, the Medios, it's very good. It's validated software and it's an offline AI. You don't need an internet connection as such, which really helps it being more user friendly. And as Arvind sir was pointing out in telemedicine, we need the patient to nowadays without travel. How can we really get the services to them? Is something that they are asking the doctors. Can you give us something like that? That's where the Uberization of the eye care came into the picture, especially during COVID, and supporting the secure sharing of images. That is something which is very, very vital. And here you can see some of our models in Mahatma, where we do a lot of outreach and the doctors in the clinic do the telecommunication. So the Remedio home-based eye care devices that we predominantly use, you may name it as a VIP patient or a geriatric patient with regular annual follow-up, including examination and anesthesia, which I'll just show in the next few slides. So this is our model, our own video that we made at our center. You can see our technician carrying the suitcases, which we call the home eye doctor in a kit, where they outreach to the apartment or the housing of the patients that we try to, slot the appointments and then move towards. Uh, so by moving into their home or their residential area, all you need is a very small space. As you can see, the weight of the bag, 6 kgs, less than your check-in baggage in your common domestic airlines that we take. And the 4 important kits that you really value. And as you can see, again, our medical director, Dr. Meena ma'am's idea is this homemade thing, where we take it in with amazing screening devices that comes up. This is our own video that we have taken shot for this event as well. So see how easily you can actually conduct an examination for a kid, for an elderly patient. Again, starting from a simple slit lamp examination, you can see the slit lamp anterior segment examination being done. and portable handheld auto-refractometry that you can actually do at the patient's own sitting position. So the power of the eye, meaning that the auto-refractometry values, all these can be detected. I personally feel it really helps for geriatric patients. Any issues in the anterior segment with the slit lamp, you can see the slit here. Very beautifully done instrument, which I'll share in the next few slides as well. So again, these are all videos of our own scenarios where we document them. A tonometry also comes along with this kit where a handheld tonometry you can document. If again, eye care is what we use, no financial disclosure, to document the patient's intraocular pressure along with a comprehensive examination which ends with the fundus. The handheld fundus camera, which also works good in the non-mydriatic way as possible. See how quickly the fundus photography is being taken. The patient's optic nerve, at least the posterior pole, is beautifully examined, and we get an idea about what we are actually dealing with to some extent. Again, you can see diabetic retinopathy, glaucoma, and ARMD can be screened. I wouldn't say really a diagnosis of a word, but screened again with the help of AI. And then with the help of AI, then start the telemedicine with our doctor in our hospital, showing the patients their own images, and then giving a clean-cut diagnosis of how to go about things way forward. I think this is one of the models that really has worked well in the hands of our center, and we are able to do a lot of outreach activities very positively with this toolkit that we have developed, or Remedio has developed with very closely with us at a large scale. So as I told, low infrastructure cost, no dedicated room, no dark area. Patient's travel cost is also saved in an indirect way. And at the bedside, this is one of the images that I wanted to show, one of my favorite images. If you're going to do an examination under anesthesia as a glaucomatologist, or even as an ophthalmologist for that matter, see how beautifully you can get a documented fundus image of this particular baby that is being shown here, again, of our own case. So these are very important, my dear friends, because I personally would like to have this for my congenital glaucoma cases, or even for any of the pediatric patients that we take up at our center. So what is from a technician point of view is it's very, very useful because they rapidly learn it. AI supports them, and the automated focus and capture reduces the operator variability. So the operator variability gets diminished. Battery operated and remote review by doctor is again another additive tool how you can do your outreach camps in even private clinics. We started as a private clinic module, and now we are moving into DNB and an institute-based module. And patients' hospital visits are fewer, and technicians are minimally trained. So these are the benefits, and you are able to refer cases even virtually. That's where the telemedicine comes into play. So these are the specifications that we use. Again, no financial disclosures. But for the benefit of the viewers here, Remedio FOP, fundus on phone NM10, NM10 being non-mydriatic model 10 is what we use, portable slit lamp PSL D20 model, and the handheld refractometer Remedio InstaRef R20, and the handheld tonometer iCare IC100. So these all comes in a single box. And for the handheld tonometry, even the 8 field of view retina images can be taken with the ETDRS 7 segment montaged image from the 40-degree view. Again, this is another image showing the same. Once you take an image, because of the automated focusing and the retinal imaging capture that you can see on the right-hand side of the screen, how the images are being done, you get an 8 field image capture. And recently, we did one of the mega camps where we screened 1,330 patients on a single day. How was this possible? Because it was possible because of this model that we were able to, employ at our center. And even for an outreach module, we created an OPD module there with a 10 × 10 cabin of at least 4. And 1,300 patients were comprehensively screened: anterior segment, intraocular pressure, fundus, all these three along with the AR autorefractometry. So this is something that we, or personally for me, it was a joy because I haven't never been a part of such a high impact screening module, I should say, because quantity, when it increases, the quality will tend to decrease. But with these modules, what I have felt is the quality and quantity goes hand in hand. because of the time constraint. You can see again the automated analysis is less than 7 seconds. No internet is required for the AI screening video that you can see here. The reports are generated, self-generated, which is a validated algorithm by the machinery itself, where you get the analysis done for glaucoma, for ARMD, for diabetic retinopathy, and the diagnoses are also on there for you to see. As you can see here in this image, 0.84 cup disc ratio, inferior NRR thinning is picked, inferior RNFL defect is actually picked, and it gives you a beautiful visual depiction of the same. Same with medios for diabetic retinopathy. The AI analysis generates the report. Again, these are videos that I wanted to show because of how quickly you get those reports without internet connectivity. And these are some of the generated montages and generated AI reports of our own patients. I haven't edited these videos. You can see 19 seconds. And on the right hand side, it's 33 seconds. So it's all in terms of seconds, my dear friends, of my own experiences at our center. How quickly you are able to generate the montage. See, you hardly within 10 seconds. And on the right hand side, within 18 seconds, you are able to generate the AI report. It's very useful, very user friendly. I think for the viewers out there, if you are able to get a demo of it, you'll be able to see the joy and aura that I faced when I started using these kind of instruments. And along with it, you also get the referability index as well, when to refer these patients. That also they come out with their algorithm. And the Meteos HI gives you the complete validation, and papers are out. The sensitivity and specificity of these machines are very good, and they are all clinically validated AI performances. How AI combining with these mobile imaging reduces the clinical workload is you are able to screen the patients then and there, advise them then and there. The referability reduces, referring the cases, and prioritizing the patients if you are able to triage them. Time spent on routine screening and the patient's waiting time reduces so that you give them a good experience when they come into your hospital. And the InstaRef R20, it works on the wavefront aberrometry principle, and the Shack-Hartman technology, which I'm not going into the detail, but it gives you a blueprint connected printer, which is very, very useful. And three readings are captured, and the results are in lightning second. That's the beauty of this machine. Again, the portable slit lamp that I wanted to show you again. Again, this is one of my own videos. Most of the videos which we are showing are all from my own videos, my own experiences at our center. See how beautifully you can titrate it between different filters. You have a green mode, blue, and a white illumination modes, and you can choose the slit, and you can examine like how you do on a real slit lamp, if not close to real, and see how much of angulations you can get from 0 to 45 degrees. That really makes a lot of difference to examine the patient with this slit, and you are there at your comfort, though it is handled. And of course, the handled tonometry which comes along with this kit, the eye care, again, no financial disclosures for anything, but though I may have a bias towards these as I'm using it. Again, intraocular pressure reading also completely helps me sum up my examination as a whole. So that really gives a complete data which I can get into my cloud with a Remedio, and we can have the EMR and the PACS, picture archiving and communication system interoperability, patient and population level analytics, and all these are ISO certified enterprises, which also gives data security. So these are some of the publications. I personally have a lot of experiences with these machineries. We are working out with our own data, and we'll be publishing our data very soon. And to conclude, this is a real world hospital workflow, at least what the Mahatma model, we call it the home eye doctor, the Mahatma home eye doctor, which we have cracked it in our center. Time is what I felt, which was very, very, very useful. With quantity, which you add volume, we are able to give quality as well with our outreach. Bedridden patients, even pediatric patients under examination and anesthesia. I wanted to show that very particularly for my glaucoma patients. And then AI with mobile imaging, it mixes a mobile phone, my dear friends. So that changes the whole total perspective of cost involved. And whatnot. You can use it for camps, home visits, geriatric, VIP, examination and anesthesia. It's completely your choice. Go with it. And last but not least, again, one of my favorite slides with all the faculty members of this event, my own signature, I always prefer this. Most of you are very dear friends. I think Dr. Isha and Dr. Asmita, I think I'll catch pictures of with you guys very soon. So thank you for the memories. It's always a pleasant evening with you guys, spending it on any podium. Yosi makes it even more special. And for the viewers, you can catch me on email, Instagram, WhatsApp, or my research ID. Thank you. Thank you for the opportunity to Sunandini and Team Yosi.
Thank you so much, Prasanna. That was great. The last slide was the best, I must say. That really brings the smile on our face that you have these pictures with all of us. So I think Remedio definitely has being unbiased completely. I really must congratulate the team Remedio that they have really done very well. That they have taken out something like portable street lamps and the diabetic retinopathy. I think it was already there. They have I think developed some new algorithms for it for getting it more better. So I do have a device for my clinics also, but I do not. I have not purchased it through them. It was a second-hand device, so maybe that's why they do not know it. So over to you, Dr. Gunjan, to the final questions, please.
Yeah, so very nicely presented, Dr. Prasanna. All the time, whenever you're presenting, it's like very inspiring to look at those models. And sometimes you are just thinking that is it real or not? Okay. So that was really nicely presented. So as Dr. Meena ma'am is working in the same setup, I would just like to ask Meena ma'am that how did you start all this idea came up to you and you started all this, and how did you train your staff to manage all this? How challenging was it, the whole thing?
See, one way of practicing where patients are going to reach you, it's very simple and very easy. But when you decide, when you have a call from within, like you all are, I'm inspired by all of you youngsters here. You all want to reach out and help the needy people. And me and my husband and my family members as well, we all believe that as human beings, we have to give away. And whatever our education, our experience, expertise, and our knowledge is going to be the same for the rich and the poor. And Dr. Sunandini was also asking me how challenging it is. Me and my husband used to say it is as challenging as mixing oil and water. It's like having technology on one side, a premium practice, technology updation, and another side is another extreme of it, where you need lots of manpower, time, physical work. That too, especially when you start crossing 60. So there are ways. You said in one of you said there are ways. You find ways. And initially, what we did was we were very particular about this, and we approached the college where me and my husband used to deliver honorary lecture to the rehabilitation science students, and they will give us 15 students in return as volunteers, vision volunteers. So they came to a clinic for 15 days where we spoke to them about eye disease, how to identify squint, what can be done, why squint should be addressed early, all those things. And then we took them for screening. So first year we could screen only 4,500 children in schools. The doors were not opening for us where bigger institutes existed 30 years back. And then slowly we penetrated. It is of course physically very challenging. Very challenging. There is no refractionist, and children are, that too less than 10 years of age, it's even more challenging. And pre-verbal children. My husband is a pediatric ophthalmologist, and initial years, like I used to go out and refract all the kids. So it was all physical, but it's okay. We survived, and so are you all going to be. We grew, so you all are going to grow. So be part of the society. There are ways. Then soon volunteers come. One retired Chief Education Officer, Mrs. Mangalam Subramaniam, she saw noted this work. She started her journey and ended her life with us. Several years. They came to volunteer, writing registers, all that. Then so many of them, philanthropic people from society. Mrs. Ansia Tong from Gujarat. She is still with us after 8 years of age. They, like attacks, like the people start flocking around you and volunteers. And we started the butterflies, the college students. We transformed them as vision volunteers every college and screened their college and one school using them. So 15 minutes, 100 children, like that. So we find ways. It is challenging. It is challenging. It's not easy, but we strongly believe we have to do it. This is a noble profession, and this noble cause must be extended until poverty gets eradicated in India. It has to be done. And you said that it helps your practice also. These children, when you give classes, they are seeing well. They are bringing their grandparents. They are bringing their parents. For refractive error and then for cataract surgeries, you grow more and more financially, and so you have more money to help the poor and needy, and that thing, it should go off, the poverty should go off. Until then we have to be a part of the society. And the mobile suitcase Remedio, now we have started knocking at the doors of the retired employees, the apartments where children have left the country and they are settled abroad, and they're not people to bring them to the hospital, but they are quite rich. So we are knocking at the apartments and they are so happy. But it's not easy. They ask why you want to do it. Are you doing it for money? Will you treat us free of cost? Even the rich people dwelling in apartments, only aged husband and wife with their parents, much more aged. But it's taking us a little difficult to knock at their doors. And this training them technically took us 15 days time. 15 of them are trained on this suitcase. It's not anchored, it has to be positioned on the eye, and the subjective refraction has to be done. So we'll locate a place 10 feet where subjectively we confirm as well. I'm sure you all are more experienced as well. We have lots to learn from each other.
I think Dr. Arvind sir also wants to add something to this point, maybe.
So,
Arvind sir?
can you repeat the question, Dr. Sunandani?
So actually, we asked ma'am that how difficult was it to train her staff while, starting this outreach programs. But we have another question for you, sir. But
Yeah. So,
because you are into so much of innovations, we know this. So how do you see in the future that, the AI can be incorporated more into this outreach camp so that it becomes easy for the clinicians, especially in government medical colleges? We know that the doctors sometimes are less, the patients are more. So, it can decrease the clinical workload on this.
So, thank you, Dr. Sunandani. You raised a very pertinent, valid question. So, it's a journey. Right. So means if we talk about means so there the AI as well as the AI component integrated with the teleophthalmology, it imparts that advanced features like flexibility, portability, integration with the internet. So it's very useful and it's the future. There is no doubt about it. Because there are more than 6 lakhs villages in India, and out of those villages 3 lakhs, they are mostly situated in the peripheral or the remotest of the area, and so many in the difficult geographical terrain. So where the reach, if we talk about any eye care, starting any eye care center, so it has means a lot of infrastructure involved. But if we reduced it, so gone are the eras of the those telephones when we used to dial numbers like this. Now it's all mobile. So there are a lot of means improvement as our Prasanna, our digital bond is there, right, to guide us. So he has done a lot of work in that. So previously there were a lot of problems, the medical legal issue, no, but now that has been solved, and most of the things the ministry has cleared that. So yes, it can be used in teleophthalmology, but with anonymity and with triple layer of the patient data, and keep their the identities anonymous, and then integrating it at the peripheral center. So any means the optometrists, the nursing officers, even these ASHA workers. We have also trained ASHA workers in Jodhpur, and the experience was really good. We did this rapid assessment of avoidable blindness with Dr. Sumit Grover, RP Center, in the leadership of Professor Praveen Vashisht. So we also went door and door, all our residents, including me, some in some camps. So it was a very great experience. So this is the future, and we must look forward. So problem we face now, coming to the problems. So main problem was the image size. So then came the idea of WebP. So that reduces the size of the overall size MB into KB, but still it maintains a very good resolution and all the details and the ocular biomarkers of any fundus picture. So this is how, now coming to the lot of pictures, they were not gradable. So we, in our innovation, in our that camera, we did this contrast, means it can be modified, color can be modified, even the red free image can be there. So all these zooming ability and the capacity to upload means more than one picture. So if one picture, one image is not all right, so then there are three images. So this is how it helped in that.
I think Dr. Gunjan also has one question to ask you. I think
Sir,
she was waiting for a long time to ask you that question.
Thank you, Gunjan.
yeah, yeah. So, sir, you actually everybody knows that you have done a huge amount of work on AI-based retinal disorder screening, diabetic retinopathy. So, I just wanted to know, like, you just talked about what one question which I was actually thinking about, that how did you improve the resolution? Because sometimes the resolution is not really good, and then AI tends to pick up all the artifacts, and then it misreads all the results and outcomes. So, I mean, I know it's long topic for you, and we need a long, webinar for that. But just in few words, how would you describe what was your learning from the screening program that you had already done, AI based one?
Yes, it was a very long, means a long journey. So I will try to cut it short and within few minutes for the sake of time. So we started with the 50 multi-centers in India, having this VR specialist and the medical retina specialist all over India. So the hindrance was the data. So once we get all the ethical clearance, then we went on and then we built this three triple layered security system. So even whomsoever is annotating that image, they don't know the identity of that patient. That was the first thing, and the ministry approved this project. So we are very thankful to the NILET as well as the Ministry of Information and Technology for giving us this much of grant. And now coming to the resolution. So there is this conversion of all the images in MB. Original, the image, whatever we take is mostly in MB. So that has very good resolution. Coming to the artifacts. So to negate that, we need to have a very good data sample size. So there is no study in all over the world that has more than 2 lakh images data set. Then we incorporated deep learning and the convolutional neural network. And finally, it was a decision tree based structure based on the ocular biomarkers, whether the patient requires a referral or doesn't require a referral. This is how it works, and we were successfully, and the study already published in Clinical Ophthalmology, and very soon the second study is also coming up.
Thank you so much. I think Meena ma'am wants to add something, ma'am, please.
Yeah, please.
Question to Dr. Arvind. Sir, government order approving our telemedicine practice.
Yeah, it is approved, but the anonymity, the data must not go in the hands of the wrong people. Government has approved it principally.
Do we have written orders from the government on that, on telemedicine practice?
Yes, telemedicine. I have a few from the government of India. I will share. I will share.
That will be very useful, sir.
Yeah, definitely.
That is, we are trying to make it as much as teleconsultation as possible, so that we are catching up with the technology. And I think soon the apps will come where the refraction will happen at home, and fundus interpretation and the spectacle selection and all that. And patients are going to come to us only for surgeries. That's what
Ma'am, you have
And the
raised a very
refractions
good.
are anyways happening at home with the help of this, apps like Lenskart, and all these people have come up with these mobile devices where they're actually coming home, just putting the vision chart. They have the PD meter and everything, and they are doing the refraction at home. It is, at least in New Delhi, it is a trend now that people are hardly going to the eye specialist to get a refractive error check. But obviously, the people who are smart, who knows the difference between these optometrists who cannot do the refraction properly. Obviously, there are a lot of optometrists who do refractions very well, than us. Definitely, they are there, but it has definitely started, ma'am, I think.
Individual app for a person who can download and check the diffraction of his own self. It's not yet come.
Oh, no, no, no.
Really neat. 6 months back, I saw auto refractometer which was like a kaleidoscope. It was mounted on the floor. I don't know if you all also took a look at that. I was impressed, sir. It binocularly, you just keep your face on it, and immediately it gave 5 readings. This happened within 10 seconds. And the values were very reliable, sir. Is there a auto refractometer which you need not verify subjectively, which is so proven like that to anyone of your knowledge? Is something like that existing? This looked like that, sir. This machine looked like that. It's from
Yes.
Italy.
So coming to the the validation. So validation part is still means lacking in the research world. So we need to wait for that, because that requires a lot of validation. Nobody can compare this refraction after cycloplegic dilatation and all that.
So
Thank you.
with this, I think, Dr. Gunjan, we can move to the next panel question for Dr. Samita ma'am,
Yeah. So
and then we
Samita
can
ma'am,
just
actually,
finish up here.
yeah. So Samita ma'am, actually, so you just talked about that you had started screening programs also as a private practitioner. So one thing which always a private practitioner looks into is the cost effectiveness, and then how feasible is it, and is it bringing something to you in when you're starting this. So and I mean, how would you say about, like, how did you start all of this, and what were the initial hurdles that you had faced in terms of cost and challenges in that?
Okay. So in terms of cost, initially it was self-funded. I decided to just fund it myself. I had joined a second generation practice. Nobody wanted me to even look at them because I was too young. So it was actually a way for me to acquire patients for myself, in complete honesty. And I had worked in Dharvi slums with Aditya Jyot for 3 years. So outreach was already in my blood. So I came to a premium private practice. So I decided, okay, I'm going to find my own way. So connecting with corporators, politicians, honestly, in India, that is the only way to do it. Whether you like it or not, whether you want to connect with different different groups, it doesn't matter. The safest and easiest way is to connect with all of these corporators, politicians, rotaries, like ma'am said, all of them, and in an unbiased way, so you do it for everybody. And then they help you organize the screening, and then we would identify the patients who needed further management, get the rotaries or them to get the blood test done from a local place, and then either organize transport or send them to the clinics and operate. It's always been a very small part of my practice, but it grows quite significantly when the work is good. And it's a challenge. Now, what happens with funding? Like you asked me, the important thing is funding. So the initial part, of course, I self-funded. Eventually, when you have premium practice, you also have other patients who want to help. You have relatives who want to help. You have friends who want to help. And honestly, people are inherently amazing. You just have to ask. So I've learned this lesson in my journey, that just ask. What's the worst that will happen? Someone will say no. So I ask, and I ask very freely, very openly, with no shame, because we are doing good for people, and people give. And eventually you can, if you once you create your own Section 8 company or not for profit company, or you work with another trust, of course you can start looking at CSR from larger companies, because at the end of the day, all the companies need the tax exemption. They all need to give some certain amount of CSR. Being in Pune, where there's a lot of industry, you do, and lot of IT, they all have CSR budgets. Sometimes you're lucky enough to have those people as your patients, so you start targeting them slowly, and you start asking them for more money. So honestly, for me, the lesson in this journey, and I have a long way to go, is just ask. Keep asking. You're doing a good job, so there's no harm in asking. And that's been my journey. And I think, now I have support from someone who's going to support me for the next 5 years for school screening. So this just keeps growing. Like ma'am said, they managed to screen lakhs of students. I've only managed to do 15,000, but for my scale, 15,000 is better than zero. So that's how I, as a private practitioner, grew. And I suggest that everybody should try to do as much as they can.
Thank you so much, ma'am, for your insights. Dr. Avnish, how do you think that things are turning up, for the financial and operational barriers in this outreach mobile devices when they're giving you all this, you told that there are multiple centers which are now connected to this tertiary
Yeah.
center. So what are the operational barriers that generally you see that we have in these mobile devices?
Yeah, so I mean, in our setups, like if you talk about a one tier sort of a place, so if you want to actually have connections where we are talking about our outreach programs, and in our sort of a setup, we can actually have connections with the optical shops or maybe some diabetic clinicians. So these are the places where you can actually keep in your fundus camera, or at times you can go and you can ask them for screening. So even that helps in, increasing your outreach. As far as the constraints are concerned, it is still difficult, because it is still not out at the end of the day. But post-COVID, I think people have become more literate people, as there were some discussions about refractions as well. So with time, I think the apps have become cheaper. The people have understood that the technology is better, and with time, I think it will be much cheaper and the outreach will definitely grow in. So initially, yes, I think we do have constraints of late. I think there are things where it doesn't sum up to what your expectations are. But then again, I would congratulate Dr. Samita, like to go head on and ask for money or maybe go in for contacts. So I think even in our setups, it is required when you have the demand. I think if that is what the concerns are, if you have the demand of these sort of patients, I think the monetary things will come into effect. And as far as I think one more thing which I think I could understand from Dr. Uh, what do you call, Prasanna's presentation. I think apart from screening, you require a group of people who can, a manpower, where they can actually do. So to actually have that logistics, it requires definitely money. So where you send in 4 people of your setup along with the amount of machine you're buying in. So that is actually, if you have your own setup, or if you are trying to have something like a multi-chain hospital. So that is a long shot where you actually have to show in the amount of patients which will come to your place. And that does have the reciprocation, as ma'am was saying, where the once you screen these patients, they bring in their relatives and all, and then that is where you do get your reimbursements. So it will take time, but I think we are definitely moving ahead with it. So maybe next 5 years down the line, as AIs will go into AI clouds and all those things will become very accessible to people. And we do not know, no? Possibly, in the next 5 years, we will have OCTs on our phones and apps. So the outreach will definitely increase and the cost will go down. Yeah.
Thank you so much, sir. Dr. Isha, I think I hope you are there. Internet you wrote a little unstable, maybe. Dr. Isha, are you there?
I could see.
Gunjan, can you ask Dr. Isha a question,
Our
please?
internet is unstable.
Yeah, I think. Dr. Isha, are you here? Hello, Dr. Isha.
Yes, I'm here. Can you
Can
hear
you
me?
hear us? Yeah, we can hear you. Can you hear
Hi.
us?
Yeah.
Okay.
Yes, I can hear.
Okay. So, Dr. Isha, you were talking about.
So answering you, yeah,
Yeah, sorry. You
yeah,
were saying something?
yeah, I was there.
Okay,
No, I was there.
we
So
were
do I need
asking
to
you.
answer the
I
same
think there's
question
some
or
lag
something?
behind.
Yeah.
I think there's some lag in your on your side, I guess.
Yeah, a
Gunjan,
little
you
bit
can
of
just
lag,
ask
but am I
Dr.
audible?
Isha the question.
Yeah,
Dr.
so
Gunjan,
Dr.
you can just ask Dr. Isha her
Yeah,
question, please.
yeah. Dr. Isha, are you still here?
She's here. Her internet
Yes,
is
yes,
unstable. You
yes.
can just ask the
Okay.
question.
So, Dr. Isha, you were talking about mobile cams also. So, I just wanted to know whether you like the mobile cam system, or you just want to, go ahead with the, on-site cams. What do you prefer? I mean, now you have both the experiences.
So what I would say is, when you have the mobile cams and when those fully furnished vans go into the villages versus when you have camps where, where we go in with just the basic stuff like the chart and a torchlight and maybe one direct ophthalmoscope. So I feel from the screening point of view, things don't really change much when you have to do a basic screening. But what changes is the patient's perspective. Because what I feel is patients from the very basic grassroots level, from the villages, they have not seen things like fully furnished van and things like that. So when those kind of things go, they do the announcements and, we say that such and such van is going to come to your location, even to the ASHA workers and the village head. I feel that creates a little more impact in just gathering the patients initially. And obviously, when you have a fully functional van, you can screen in for more conditions. But I would say even doing regular camps without the van is also very effective in screening the patients, because if we have a trained team, say of an optometrist, technicians, vision technicians, I feel they would do a wonderful job, uh, even not having the van. So obviously having a fully furnished van, mobile eye clinic is a big advantage, but not having that would also not kind of deteriorate your screening or services. So yeah, that's what I feel.
Just a
Thank you
small
so
query.
much.
Dr.
Yeah,
Sumit
sorry.
also just wanted to have an idea about this mobile camp from Dr. Sumit. You were introducing about these vans that you talked about. So what's your experience about it? What do you prefer? Like, is it better than the on-site camps, or you think that this is doing a better job?
So thank you, Gunjan, for asking this question. Basically, we cannot compare. I mean, both the things are same. You know what I understood from your question. Basically, we need to compare the fixed facility centers, which are vision centers, to the mobile vans. So the advantage of the mobile vans are that the fixed facility center is there. We have some standalone vision centers and some with the government dispensaries or around the mohalla clinics with the Delhi government. So the thing is, for the fixed facility center, the problem is that you have to send your optometrist or your staff daily to that place, right? And eventually, because the vision center covers a fixed area, kind of a fixed cluster of population, so it's like sometimes it's like the it's not a wastage, but it's like underuse of the or under allocation of the resources. But if you use the mobile van, that the same team can visit three places, can reach three clusters at the different set of population where the unmet need is more. So in a way, that if you want to increase the reach of your eye care program, then the mobile vans are very useful. But the problem with the mobile van, that the follow up, the trust, the follow up, because at the fixed facility vision center is there, then the trust develops more in the community, that yes, always the optometrist is there in case of any subtle primary the requiring primary emergencies, like that the people are there, the follow up is good in the fixed facility centers, while in the mobile van the reach is more. But the problem of follow up to the mobile vans or because these are very much, mobile, and you can send on a very much fixed days on a roster basis. So these are some pros and cons of mobile versus fixed facility. Otherwise, camp is a camp. Like, we don't prefer camp. Camp means you go, you screen, you come back. Then there is a huge loss to follow up. Always you have to, do something like a fixed facility vision center or a mobile, where, the people knows that, yes, I have to go back there at least, or, somebody is there on this particular day, I'll go back and show them. And then you advise them, and then they can go to your tertiary care center. So camp based screening is now outdated. Only the fixed vision centers or the mobile van based screening or the outreach, that only works.
So I have a take on this. So we, as an hospital, we also run a lot of camps on day-to-day basis also, and we have three models that we run for camps. One is run by the hospital as as a service to the society, where we go, we check the, vision of the patient, we screen the patient for cataracts, we do the ECG and the sugar and the BP of the patient. So this is like a service to the society that we are giving. So we have tie-ups with different NGOs, different optical shops, different medicine stores, or, people like them, or some influential people. Then we have some specific eye camps that we do. So these are generally camps where like I and one of my doctor, we generally go along with our optometrist. We take the full system of our, slit lamp, our vision charts, our refraction, everything we take. And then we have something that we do inside the hospital, inside the or on-site camps. So I think the patient turn up in the hospital when we do the camps, it gives you the most amount of visibility when they come and they see the, infrastructure of the hospital. They get to understand the infrastructure, and the follow up on these patients are the most, rather than the other people, like as you also said that, in mobile camps and going to different places and bringing the patients are generally lost to follow up.
Yeah, and also
So
the trust factor is also very important. What the
yes,
first
true.
model you have suggested, or what you were doing, like the people consider that as a, kind of a sort of a marketing camp only. The
Yeah,
community understand that they have came for, just hunting for the cataract, and then they will
true.
call us, and then they will counsel us for the premium IOS and everything.
Yes,
So,
yes, right.
everybody is like well aware nowadays. So I think
True.
the next two models you have suggested, they work better. Yeah.
Better. So because they see the infrastructure that you have, they somehow
Trust
the
build
moment
is
I think
very
they enter the hospital
hospital.
building and
Yes,
they see the building, the infrastructure, the trust automatically comes, I think.
agree.
Thank you. So with this, I think we come to the conclusion of this session, and we are very honored to have our chairpersons and our panelists with us here today. So I would hand over to Dr. Gunjan for taking the final vote of thanks from all our chairpersons and panelists, please.
Yeah. Thank you so much, everyone, for this wonderful evening, and Dr. Arvind sir and Meena ma'am for taking out their precious time to be with us. And we are truly humbled by your experiences, and all the panelists, Dr. Samita, Dr. Isha, and Dr. Avnish, for giving us all the experiences they had, and the wonderful speakers, Dr. Sumit and Dr. Prasanna, for giving us their insights and the reality behind the imaging and the outreach camps. I thank so much Dr. Sunandini, who has been a pioneer and and a spine behind this kind of webinar. She's always been there, getting out good ideas from all the good people around. So I would like Dr. Arvind sir to give one remark for this evening, and Dr. Meena ma'am as well.
So it's a great initiative by YOSI. So hats off to you and your team, especially Dr. Sunandini, Dr. Gunjan, and all your team. And the talks were really excellent and very relevant in this modern world, because change is the only constant. Nobody knows Nokia now. So we need to adapt to the newer condition, and this is the way forward. So all the very best. Thank you. Thank you so very much.
Thank you, sir.
Ma'am, you are
And
on mute, ma'am.
I think this is what we call generation gap. So keep spirit on YOSI. It was really inspiring being with you all and hearing lots of things from Dr. Sumit Dr. Gunjan, Dr. Sunandini, all of you, Dr. Samita. Thank you and wish you all the best and Happy New Year.
Thank you, ma'am.
Thank you so much, ma'am.
Dr. Sunandini, I would like you to give your insights next.
I think Dr. Sumit's talk and Dr. Prasanna's talk really, concises it to the point where, how we can start this Irish programs in all kind of cities and all kind of, settings are very helpful for our young ophthalmologists. Dr. Sumit, your take on this evening, please.
Thank you. First of all, my regards to the chair and the panel, and thank you, Dr. Sunandani, for organizing, and Dr. Gunjan for excellent moderation. So the only take is the community eye care services can be done by everyone, anyone at any place. Then you just have that should have that passion and the inner call, and also there are many opportunities like you can speed up or expand your there is no just thinking about the coming to the moon and back. You can expand. There are some if there are opportunities, there are challenges as well. The challenges are lost to the follow-up. You just screen them, they do not come to the tertiary care center. There are some kind of challenges as well which we can mitigate by using this portable equipment on the in-house eye care services and things like that. So I think community eye care services are not limited to any person. They are universal. The principles are universal, and any one of us, group practitioner, private practitioner, corporate practitioner, NGOs, Section 8 companies, anyone can do with free will and free spirit community eye care services. That is the gist. Thank you.
Thank you so much, Dr. Sumit. Dr. Prasanna.
Yeah, Pranandani, thank you. Just being on the other side of things, me being into all this smartphone kind of a things and trying to do what more. So what I learned from Dr. Prithvi Chandrakant, again one of our dynamic YOSI members, and some of my seniors, Vishnu Teja, when I was his younger PG. He used to show me a decade or 12 years back with a 20D diopter and a phone. He told you can see the fundus. I was fascinated. Similarly, Dr. Prithvi developed ASPI, anterior segment phone imaging, just by a 120 diopter lens or a 30 diopter lens, putting it in your smartphone. You can view anterior segment structures. Trash to treasure was another innovation of his when I was working very closely with him during COVID. So what these gave ideas were that I think with the smartphone and we can definitely uh, conquer economical portable practices outreach programs. So I think that's what Remedio has taken it in a very serious plane, and I'm following Remedio's work for a very long time, and I think that's where my real forte comes in. So most of our outreach activities are all the brainchild of Dr. Meena ma'am, and I think credit where credit's due. So we are just trying to make sure we continue the good work that she has done. And thank you once again, Sunandini Gunjan. I would just request Dr. Chirag, with your permission, Dr. Chirag or Dr. Swati to share their inputs, because I think that will give us a complete closure. Yeah, Mr. Chirag. Yeah.
Yes, I wanted to say thank you very much. We are not doctors, by the way, Dr. Prasanna,
Yeah.
you all are
Sorry, I
doctors.
introduced you wrongly. Mr. Chirag and Swati ma'am. Yeah, sorry.
Yes,
Apologies for it.
it was really, it was a very great session and very grateful for all your time. We would love for us to be able to reach out more to your members any way we can help with screening, with outreach. We'll be very happy to help. So, loved all the talks. Again, thank you very much. Very grateful.
Thank you so much, Swati. Dr. Samita,
Thank
are
you,
you
Dr.
there?
Sunandini.
Mr. Chirag is also here.
Yeah, Samita ma'am, are you there? Or ma'am has left? Samita ma'am? I think ma'am has a flight to catch. Okay, we can take it from
I'm
Mr.
here, I'm here,
Chirag,
I'm
please.
still here.
Yeah, ma'am. Yeah, ma'am. Please, your take on this evening,
Anything,
ma'am.
I really enjoyed it. I think there's a lot, there's too much inspiring work out there. And I think Dr. Grover's talk was very inspiring. Of course, Arvind sir's work is really legendary. Always amazing to hear Prasanna, my dear LDP batchmate, talk. I love the kit that has been created by Remedio. I use half of it, yet to get the whole kit or get the refractometer, but fantastic, platform UC gives, and great session. Thank you so much.
Thank you so much, ma'am. Mr. Chirag, your comments,
Yeah.
please.
Yeah. So thank you so much, UC. Thank you so much, Dr. Sumit, Dr. Prasanna, Dr. Sunandini, and each and every one of you all, Dr. Meena for sure, for taking the idea that we discussed with Mahatma Eye Hospital for screening and using in different perspectives, very specific. It was be it home care, be it outreach, in clinic. So thank you so much, and looking forward to work along with each one of y'all and for a better mankind and preventable blindness. Thank you so much, everyone. Thank you.
Thank you so much, Mr. Chirag. I think I must thank Remedio team member Mr. Avinash that he was from the onset of I think YOSICon talk till now. He was with us to plan two sessions so that we can reach to the young ophthalmologists, make them understand that how mobile devices have evolved throughout the years, and he wanted to involve not only Remedio but the concept of AI into us. And for this particular webinar, I had made him wait a lot because we had some more webinars with the YOSI Career Portal. Thank you so much, Mr. Avinash, for hearing with us till the end. And with this, I think we come to the end of the session. I'm very, very thankful to our chairpersons, Meena ma'am and Dr. Arvind Moria sir, our speaker, Dr. Sumit, Dr. Prasanna, for being here with us, our panelists, Dr. Samita Malani ma'am, Dr. Avinash sir, and Dr. Isha, who are there with us. And I'm extremely thankful to Gunjan because she planned all the, uh, uh, discussion questions with us. And I also want to take a little time for Prasanna to invite you all for the next YOSICon that we have in June 2026. Prasanna, if you can
Yeah,
invite
yeah,
our bios.
yeah. So to all the viewers out there who are listening to us. So this is what YOSI is. You guys will be seeing all our activities. So we did have International YOSICon this year, September 5, 6, and 7, which was one of the uh, second events, but the first International YOSICon happened this year, and next year we are planning to do on June 19, 2021, again at Hotel Pullman, New Delhi, and I think the work of YOSI speaks for itself today, being a YOSI carrier portal. And we are trying to bring out new initiatives, modules, which are very practical point of care initiatives, which benefit the community, benefit the young ophthalmologists, and we all grow together along with our global colleagues and industry partners. So please do be there. And you may find us all in different costumes as well. My June bot buddy, last time when we had a similar podium in Remedio, I believe I was totally the misfit in Joker's costume from Ophthalmic Wars. So you have everything in YOSICon. That's one of the reasons why you should attend YOSICon. So thank you, Sunandini, for asking me to invite everybody. I think we'll definitely do much better than what we did this year on a more grander scale. Thank you. See you all in
Thank you so much.
YOSICon.
So Nandini,
Thank you
can
so
we
much.
have a kind of a group picture? I mean,
Yeah, we are
just
gonna
one
take
buddy.
that only. I was
Can we do
just
something like that?
we are. I was just gonna invite everybody to make the bio sign so that Manjula can take the group picture for us. Manjula, can you take the group picture with us? I asked the Remedio team also to please switch on their camera and do the bio sign, please.
Who is taking the screenshot?
The Manjula is gonna take it. She does it every time.
Okay.
Manjula, let us know once you are done.
Done, doctor, done. I
Thank
will
you
take
so
it.
much,
You.
Manjula. You have
Thank
been
you.
really helpful from the very start. Thank you,
Welcome, doctor.
Team Numeratic. Thank you, Avinash. Thank you, everybody. A very good night
Thank
to
you.
everybody.
Thank you,
Thank you,
everybody.
Sunandini, for bringing us
Thank
all
you very
together.
much.
Thank you, Sanandani. Thank you, Gunjan, again for bringing us all together. It was such, it felt like homecoming, especially the last slide you told. That was the most toughest slide to make. I'll share it. If there was a WhatsApp group, I would have shared it. But anyway, it's fine.
Okay, bye everyone.
Bye,
Thank
bye,
you.
bye,
Bye,
Sunandani.
good
Bye,
night.
bye.
Thank you.
Thank you.